I'm Nicolette Sinclair. I'm one of the interventional radiologists at St. Paul's. My project was around using ultrasound for follow-up of endovascular aortic repair, so EVAR is what I'll call it, just for short, because we don't have time. Background, so EVAR is used to repair abdominal aortic aneurysms. It has largely replaced open surgical repair, decreased morbidity, mortality. It's a fairly well-accepted way to treat these patients. Though unlike open repair, patients who get EVARs do need lifelong imaging follow-up. So this is just the state of the number of EVARs we've done in the health region. In 2012, we did about 2, and now we're up to year-to-date 2017. We've done about 63 EVARs in health region. They're done by both vascular surgeons and interventional radiologists. Between 2012 and 2013, we got a new vascular surgeon, so you'll see that that is where the jump came from. So here's just an example of what I'm talking about when I'm talking about follow-up. So here is a CTA, and there's IV contrast in the limbs, these 2 little circles. That's the EVAR limbs. Here is contrast outside, so this patient has an endo leak. On Doppler ultrasound, you can see this, the same thing very well. You see contrast blood flowing, or sorry, not contrast, blood flowing through the limbs of the EVAR. Then you see there's also blood flowing outside of it, and it's actually being fed by this little artery, the inferior mesenteric artery. So currently in the health region, we do exclusively CTA follow-up of these EVARs. Ultrasound is a proven way to follow these up safely after 12 months. So my project was to develop a program where people who can appropriately be followed up with ultrasound are transitioned from CT to ultrasound follow-up. Decreased ionizing radiation, decreased IV contrast. It's also cheaper. That wasn't the whole point. So it's an appropriate way to follow these people up. So I thought it was very easy. I'd roll into a meeting and everybody would praise me and they'd say, let's do it, no problem. Appropriateness, decreased radiation, great. Did not happen that way. First mistake was I went to a meeting without any data and I just said, let's do this. And everybody assumed that there would be hundreds and hundreds of ultrasounds that would be needed to be done. So I got an immediate no from the managers of the ultrasound techs because there isn't enough techs in the hospital. Next thing I did was develop a program to train the technologists in the community clinics because there's capacity there. So I worked with one of the techs. We developed a program, had some volunteer patients come. We scanned them. But then we realized that really these studies should be done by experienced ultrasound technologists and experienced radiologists that are experienced with vascular ultrasound. So that was a failure. Well, not a failure, but I learned from it. Third thing I would have to come up with was a way to get these things done in the hospital. And so I tried to come up with a way to streamline the ultrasound technologist workflow in the hospital. For about 1 week, it was a glorious week. Everybody was happy, the techs, the radiologist at St. Paul's Hospital. But then again, somebody who doesn't work at St. Paul's Hospital caught wind of it and shut it down because I didn't ask for permission. It was, again, it was my fault, but I just wanted to do it. After Paul Chifa came and said, just do stuff, I started just doing stuff. Yes. And the other thing, I'm almost done, and I will give Carla some benefit in this. She was helping me with my charts because I'm not that good with Excel, but I had been presenting the data as how many ultrasounds are we doing, how many CTs are we doing. Her idea, or the idea of the CQIP staff, was why don't we frame it as let's track the number of inappropriate CT scans. So I went back and looked through all of the EVAR follow-ups that we did for 8 months. We did 101 EVAR follow-ups in 8 months, so the volumes aren't as high as everybody assumes they're going to be. And of those 101, of those 101 CT follow-ups, about 46% of those were unnecessary. They could have been done with ultrasound. The word inappropriate still is a bit hurtful to me, but it could be at least deemed inappropriate CT scans. Anyway, what's next? I won't back down, like Tom Petty, and we're going to continue on. And I have some ideas of where I went wrong. Maybe asking permission is a good idea. One unexpected improvement, and I forget Dr. Shaw or Guter, everyone was talking about the changing the culture. And when the CT techs caught wind of what I was trying to do with ultrasound, they said, well, we're inefficient. We want to do something too. So we came up with a plan, and you can come talk to me about it. But I found a screwdriver and screwed this into the wall of one of the offices. It's a folder that just says add-on recs to protocol. And it's amazing that that one little thing has completely changed the way the techs work. They're way more efficient. we're happier, no one's fighting as much at St. Paul's. Anyway, so that was an unexpected outcome, and I think it's because the culture, people are thinking of ways to improve.